Okay, so thank you everybody for coming, and I'm excited to talk to you all about TATMEs. We've only been doing them here for 2 years, but I'm going to tell you a little bit about them, a bit about TAMIS, how many cases we've done, and talk about this more advanced platform and its anesthetic considerations. We've been doing these at Royal Columbian and Eagle Ridge Hospital. Myself and Dr. Melick are primarily the two colorectal surgeons here that are doing it. Dr. Chu and Dr. McKenzie have also joined our team, and so now they are currently actively training to do the abdominal portion of this procedure. So we'll have a group of 4 people that are able to do this for rectal cancers, and I'm going to talk a little bit more about this. And this slide is just to demonstrate the challenges that I have gone through in preparing this presentation for all of you. Uh, in addition to being called at 4:30 this morning to come in for this laparoscopic examination. So basically what I'm going to do is talk about the procedure of transanal resection, so just plain TAMIS, transanal minimally invasive surgery, as well as TATME, which is transanal total mesorectal excision. We're going to talk about the patient selection, the difference between this and other colorectal procedures, which patients benefit, what's the importance of the TME, the total mesorectal excision, because that's absolutely key in this operation, and talk a little bit about ERAS, and we have Richard here, of course, to comment more on that and how it's specific to this patient population. Unfortunately, Brenda is in Toronto for a conference, so she So as a colorectal surgeon, when I came to Fraser Health 4 years ago, laparoscopic transanal excisions were the only procedure that I wasn't doing here. So, and we were sending all of these patients to St. Paul's for their local excisions. So anybody who had a polyp in the rectum, cancer, low-grade cancer in the rectum that was basically above the dentate line, we were sending them to St. Paul's to have their procedures. Now, this is what St. Paul's uses. This instrumentation is called the TEM, not to be confused with TME, which we're going to talk about, but this TEM instrumentation is a rigid platform that they use. And as you can see, it's quite a setup. It's set up on the bed. It's a rigid platform. And it's an expensive procedure. It costs about $40,000 for this setup, and you need to have at least 2 setups, because if something goes wrong with one, then this is, the alternative. You need a second one. In addition, the positioning with this traditional approach it has to be modified for every patient. So because it's a rigid platform, you have to position it based on the tumor location. So that's a bit of a challenge. What about the technical part of it? Well, the working angle was increased because the TEM has a much longer insert. The TAMIS, as you can see, and lots of you have seen this, is a much shorter one. So the working angle laparoscopically is easier. And why does that matter? For the TEM, you actually need dedicated laparoscopic equipment and angled instruments, oftentimes angled cameras, in order to excise these lesions. So it's a completely different skill set from laparoscopy. The learning curve is quite high. It's something that you can't really teach residents. It's quite challenging, and it's not a direct sort of offshoot from laparoscopy. So how did we do this in the past? Like, how did we take out these lesions from the rectum in the past? Well, we would do transanal excisions for lesions up to 7 centimeters from the anal verge. So the rectum is 15 centimeters, and up to 7 centimeters, we would put in the Lone Star retractor, which we actually didn't have until 4 years ago. We would, put in a ton of retractors, and we would struggle. And anything above 7 centimeters from the anal verge, we would have to actually do a segmental resection. So that patient would have a hospital stay, an abdominal incision, and an anastomosis. So it was, a much bigger deal. Why transanal excision was compared to laparoscopic TEM, which is what they did at St. Paul's, what they do at St. Paul's, and it was actually proven to be better in terms of margins, completeness of excision, and less fragmentation of the specimen, okay, and less local recurrence. Can see that? Is that, can we move that or no? It doesn't really matter. I mean, it's not, it's really in the corner. Can I drag it though? It doesn't really matter. There we go. Because these guys don't need to see. Two of me. So again, basically it was, this is the transanal excision with a Lone Star retractor, and it was a nightmare. And as a surgeon, you know that your visualization is so much improved by putting a laparoscope in the rectum and insufflating. So again, all of these things, clear margins, better visualization, less fragmentation, it's all good for any kind of cancer surgery. So if you take out a lesion and you find it's a cancer, if you have clear margins and it's a T1 lesion which is of the lowest rate of invasion, lowest depth of invasion, then you know that you've got it and that's it. You don't need to do any more, because the risk of lymph node involvement and the necessity to do an actual segmental resection is the risk of lymph nodes being positive is less than 1%. Okay, so this is an appropriate operation. So we know that laparoscopic transrectal surgery is superior. Okay, so when I came here, I thought, well, sure, can they buy me? They're going to buy me something for $100,000, and it's not just the TEM setup, it's everything. And it's the learning curve. It's a huge learning curve. Again, it would be very difficult for a hospital to buy these and to do a lot of cases. And for the same cost, we can start with something. I was introduced to something called the gel point path, okay, and that's what we use. So it is about $700 to $800 each time we use it. It uses standard laparoscopic equipment. It's a quicker setup. Again, it doesn't require capital funds from the beginning. Doesn't have to be cleaned, reprocessed, repaired, all that stuff. You can do more than one TAMIS a day. With the TEM, you can only do 1 to 2 a day because of the huge setup and the cost of reprocessing, et cetera, and the time. So we've done up to 5 TAMISes in one day. The average is about 30 to 40 minutes is our average now on looking at our database. So I was introduced to this innovative platform called TAMIS, and this was 2.5 years ago. And again, it's much improved over the platform used at St. Paul's. And I have to say, I was very just lucky because somebody introduced it to me in my office, and I was like, that looks cool. That's the one thing we're not doing as a colorectal surgeon here. That's the one thing that I was sending away. So I thought, let's try it. And so it's much more dynamic. I began doing local excisions basically over a 2-year period, and now we've done 115 local excisions and then 47 TATMEs, okay? We'll talk a bit about that. So this is just a demonstration. You've all seen this before, but this is, our port in the anus, the patient lithotomy position. This is our lesion. This is a simple transanal resection for a rectal lesion within 15 centimeters of the anal verge. And that's the tumor. Start with a full thickness dissection. You can come full thickness into the mesorectal fat. If you're within 15 centimeters of the anal verge, you're going to enter into the mesorectum and stay in the pelvis. So, we've all looked into the good music, right? We've all looked into the pelvis and see the peritoneal reflections come down. It's all below the peritoneal reflection, so you're perforating the rectum, but it doesn't matter. And in fact, leave these wide open, and the only difference is that the patients probably have a little bit more pain if you leave these defects open, okay? And but these are daycare procedures. As long as they are, 2 or 3 centimeters above the dentate line, these patients have no sensation. So usually they have zero pain. They may have some rectal pressure in the area, and that's usually all they have. So there's women distal there, with then suture closing defects. There was a study done at St. Paul's because with TEM, closing the defects, not closing the defects, again, only pain is the difference, okay? So, we close the defect here. Who knows, if we went in with a scope on these patients on day 5, they're probably all open. That's oftentimes what happens. Any kind of it doesn't matter. And that's the beauty of doing this. Even stool coming by this, it will granulate it and heal. It's amazing, and that's because of the blood supply. The blood supply of the rectum is just is huge. So that's why these patients do so well. And you can see in this video, and I'm going to talk about it a little bit later, about how air hits the plate in there and gets into the retroperitoneum and then bleb into the abdomen. And the patient can present with free air in their abdomen that actually, when you haven't actually perforated through the rectum, okay? So, and this is an interesting concept because even the gastroenterologists ask me all the time, well, gosh, we didn't want to raise the infection, we just want to perforate through. And I always tell them, it doesn't matter if you perforate through, like it doesn't matter if fat is poking through, because it seals off, and it's in the pelvis, not in the abdomen. So that's a really key to know about. The other thing I don't mention later on is just the use of, this is why spinal anesthetic is an absolutely amazing way to put these patients, to do these patients, these local excisions for TAMIS. So what else can we do with TAMIS? So we can do, this is what I'm going to talk about primarily, laparoscopic low anterior resection with transanal total mesorectal excision, so or a LAP, LARTATME. Okay, so basically it's an incisionless low anterior resection, or incisionless. I hate it when they say incisionless. You still need 3 5-millimeter incisions in the abdomen, but it's relatively incisionless. So basically, who are these patients that are undergoing this operation, the more advanced platform of TAMIS, okay? Anyone who's undergoing removal of the rectum, okay? So anybody who's undergoing a total mesorectal excision. Now, this just shows the anatomy, and there's the rectum. This demonstrates, can I point? That's okay. This here is the mesorectum surrounding the rectum, okay? And when you're doing a total mesorectal excision, and I'll explain the importance of that, it's important to access all of this mesorectum, okay, in addition to your specimen. Particularly for a cancer. If it's a Crohn's patient, ulcerative colitis, non-cancer, that's not important, other than it's a bloody mess when you get into there, because that's the blood supply. But maintaining that mesorectal envelope is absolutely key. So when do we remove the rectum? In rectal cancers and inflammatory bowel disease, usually in Crohn's, ulcerative colitis. So in rectal cancer, this is basically what the operation looks like. There's the tumor, we take out the rectum, the first part of the sigmoid colon, because of the blood supply, and we attach the sigmoid colon down to the rectum. Okay. That last one shows what we do if we're creating way over, if we're taking the whole colon out, creating a J pouch and attaching it to the and I'll show that in a second. So again, anyone who has a retained rectal stump, so if it's Crohn's, you're removing the rectal stump because of their risk of cancer. Somebody who has chronic inflammation is going to be at risk of cancer, and if they're not using their rectum and there's no plan to reanastomose, then we would remove the rectal stump. In ulcerative colitis, it's patients that are having their rectum removed. So usually they've had their intra-abdominal colon removed first, and then they've settled, got off steroids. Then we do what's called a completion proctectomy. So we remove their rectum and we create the J pouch. And we can use TATME to do that as well, to remove the rectum. So basically, it's anytime we remove the rectum. So again, what's this procedure? This is the laparoscopic low anterior section, transanal total mesorectal excision. So what's the difference between just like an LAR and an LAR-TATME? So an LAR-TATME, it's the exact same operation. It's a two-team approach. It is the same operation. What you are always trying to achieve in rectal cancer is a total mesorectal excision, and I'm going to go into that again. And that actually total mesorectal excision is so important. So, a surgeon putting your hand down there and doing this to try to get a rectum out, that's actually that's getting into that really gentle sort of like fragile envelope that maintains all the lymph nodes. And we know Bill Heald out of England has published since the 80s on this, and we know that increases patients' local recurrence of their cancer and decreases their survival. Okay, so TME is a surgical principle that we all have to follow. So somebody going in like this, that is increasing the patient's local recurrence and long-term survival. Better visualization with this procedure, and again, fewer incisions, so better recovery. Essentially, it's the same operation though, okay? We're taking out the rectum or a section of the rectum, and we're doing a connection to the residual rectal stump or the anus. So this is just a picture in 2014, I started doing the TMEs using the TAMIS device. And again, anyone undergoing removal of the whole rectum, we've done 47 to date. So you can see in this picture, the lymphatics surrounding the rectum are in yellow. And, it's critically important to remove those lymphatics with an intact mesorectal envelope. And the pathologist will actually comment on that, and they'll comment on the quality of your specimen, of your rectal specimen. And, as surgeons, we're waiting for that because we want to see that we have not compromised that mesorectal envelope. That's absolutely key for these cancer patients. So again, that's called a total mesorectal excision. Again, improve local recurrence and increase survival for the patients from their cancer. So this is a quality thing and an outcome-based approach. And every surgeon that does rectal cancer knows that they need to get a total mesorectal excision. So why do it transanally? So which patients benefit from it? What's the value of TATME? Why can't we just do it laparoscopically or even open? So, as I'm sure you've all heard of NOTES, or natural orifice transluminal endoscopic surgery. So in this case, we're not doing it for cosmesis. We're doing it because we want better results. We want better outcomes. We want a better TME, and we want to offer sphincter preserving surgery for patients that would otherwise be impossible with a low rectal cancer to complete with either open technique or even laparoscopy, even robotics. Okay. So we're doing this operation not only to improve the outcomes, but also to give the patients a better function-preserving surgery and to avoid a permanent colostomy. So a lot of our referrals here for these patients are from other surgeons that low rectal cancers. Can you spare the sphincter muscle? Sometimes we can spare the sphincter muscle. Is it worth it in a 70-year-old patient that has incontinence already to do a coloanal anastomosis and basically give them a stoma out of their perineum? Probably not, right? So again, we can do this operation. Is it the right thing to do? That's what we want to make sure those patients are well selected. So basically, this is the next step in the evolution of minimally invasive surgery. We know that TME is the gold standard, total mesorectal excision, but what are the technical difficulties of TME? So basically, the need for good visualization, using atraumatic retraction, and that's the key. You don't want to be grabbing the mesorectum with something and tear it, because again, then you've breached the mesorectum and you're increasing their local oncologic failure. So that's absolutely important. Anatomically, what makes it challenging to do this operation and remove the rectum with its intact mesorectal envelope? So the bony boundaries of the pelvis, they limit visualization. The distal rectal transection, so actually oftentimes requiring multiple firings of a stapler, and oftentimes challenges with even getting a stapler down into the pelvis. So we see these technical issues mostly in the male that has a narrow pelvis and that is obese and has a fatty rectum, basically stuck in a narrow pelvis. So basically, being unable to even perform this operation and deeming the patient reliant on a permanent colostomy is what has motivated the introduction of this. So TATME is a more advanced hybrid procedure using that same platform, 2 surgeons, you're able to remove the whole rectum. It's really the ultimate NOTES procedure, and you've probably heard about like taking the gallbladder out of the vagina just because you can. Well, that's not what this is about. This is about doing a better operation, improving patients' outcomes, getting a better TME, better visualization, better excision, improve local recurrence, increase survival for patients, okay? This is just OR setup. I'll just go through these quickly. This is the positioning. It's always in lithotomy. This is the set if you haven't seen it before. This is what it looks like. This is our insufflation device. This stuff is less relevant to you guys. This is equipment that we use, very standard laparoscopic equipment. Okay, so nothing fancy. This is how we insert it into the bottom end, and at the same time we have a second team doing the laparoscopic portion and the mobilization of the upper portion of the rectum. So this is just a good video of the procedure. So basically, one surgeon up this way mobilizing the sigmoid colon vessels, coming down, mobilizing the upper rectum. Second surgeon going in transanally. Dr. Muhammad Ali in the back here, I think. I don't know if I have his permission to use this video. I didn't. I'm going to have to give you royalties. So there we are. We identify the tumor in the rectum. Bring device distal to the tumor. So right there, that's an oncologic crystal. We've gotten a distal margin, okay? And nice music. And we're tying it off, distal to the tumor, and then we come full thickness circumferentially through the bowel wall. And then we continue our dissection around the mesorectal envelope. And anybody who's seen this procedure, you can tell where the mesorectal envelope is because there is a nice angel hair circumferentially, and that shows you where to go. Okay. So and then the first surgeon here is putting the place in the distal rectum. Once everything's mobilized, top and bottom, and this is and the top, just make sure everything's mobile, make sure the clinic section is down. Okay, and then the incision is done through the perineum. And then we put a handful of in that section of the bowel. First grade, pop it back in. And then perform our anastomosis. Sometimes we'll do this anastomosis hand sewn if we feel that there's a thin rectovaginal septum in a woman, or anything that's not absolutely perfect to do an end-to-end anastomosis, then we'll and so, why is this like, what have we seen now that we've had almost 50 experience? And there's a staple. What have we seen? Well, we've made most of the dissection from pelvis. There's very little abdominal dissection unless you're taking the clinic down or like nightmare from Fraser Health for somebody who doesn't want to do that operation. What do we see and what have we seen? Out of our 50 patients, we've had one patient that's had a leak, which is pretty consistent with any LARs. So that patient that had a leak downstream, she leaked at 2 weeks, just over 2 weeks. And she had, the only indication was that she had stool coming out of her vagina. So she had a very thin rectovaginal septum, and she had no vital sign abnormalities. We scoped or put a scope in, saw a teeny little connection to the vagina. Okay, so a staple had, it was very thin rectovaginal septum. As one of the staples had eroded through into the anterior vagina, very tiny hole. Brought her back 2 days later to take a look with the scope, and it had completely disengaged the anastomosis. And this woman, and I was looking into the sacrum basically with my flexible sigmoidoscopy, and this woman was not sick. She was in pain, a little bit of pain, like pressure down there, no vital sign abnormalities, like soft abdomen. So, we transferred her here. We brought her to the operating room with a plan to bring up a loop ileostomy. Now, 2 weeks, as you know, is like the nightmare time. Anytime over 2 weeks, you're over 10 days even. That's when everything starts scarring, and that's where the healing process, begins. And it's the worst time to go into the abdomen. And then if you want to wait, you have to wait till 6 to 8 weeks, right? So we were just thinking this is going to be an absolute nightmare. But you know what? Let's just pop a scope in, and we'll see if we can do an ileostomy on her. It was like we went into a virgin abdomen. She had nothing. There was no contamination in her abdomen. Everything was sealed off into her pelvis. We did the debridement below, just through the anus, and we could see the disengagement of the anastomosis. This patient was not sick. It was, so even and we brought up a loop ileostomy, no problem, like we were in a virgin abdomen. So even those patients that leak from this procedure, and this woman didn't have radiation, there was no need to do an ileostomy on her preoperatively. Ileostomies don't prevent leaks, they prevent the consequences of a leak. Well, we're demonstrating now that the consequences of a leak are significantly less than the consequences of a leak, even with laparoscopic LAR. But certainly with open LAR. That patient with an open LAR would have had another open procedure to bring up the ileostomy. And that at 2 weeks, that's when we get that frozen abdomen. And that patient could have probably, we have lots of those leaks that occur. They go to the ICU, we can't close their abdomen, they have vacs put on. So this is, the consequences of this leak were significantly reduced because of this operation. This is just the operating room setup. This is more for the nursing. It's called the Cecil approach. The surgeon in Spain that developed this is emotional connection to the lion that died, Cecil. So he's called it the Cecil approach. But this is an amazing website. It's the AIS channel, and if you want any information, there's even anesthetic considerations of the procedure on there. It's an excellent website. So what are the expectations with these patients? So, we institute ERAS on all of these people, of course. It's a care pathway that we use here, and we're introducing it now at Eagle Ridge Hospital. It's embedded in our order set. We all know that. So but how is it specific to our patient population? Again, probably more so intraoperative considerations. How does it change things post-operatively? I'll tell you a little bit about that too. These are just all the ERAS interventions, mostly for nursing. I'm just going to go just briefly about the anesthetic considerations because you guys obviously know more than me, and I'm not going to be telling you anything new here. But a lot of the literature addressing the anesthetic issues that arise in these cases are basically surrounding laparoscopic surgery in gynecology and in prostate surgery. So that's where, where you're working deep in the pelvis. The surgeries are longer. They require steep head down positioning, and that's where you see it. Where laparoscopy now is for colorectal surgery is the preferred surgical approach. There have been 3 studies. The first study for colon cancer demonstrated that laparoscopy was appropriate for colon cancer resections. Okay, so oncologically it was a good operation. That was called the Color 1 trial. The Color 2 trial was looking at laparoscopy for rectal cancer. So Color 2 trial has now shown that laparoscopy is appropriate and equivalent to open surgery for rectal cancer. In fact, that Color 2 trial is even showing that laparoscopy may be better for distal rectal cancers, and that's because you're getting better visualization laparoscopically of the mesorectal excision and decreasing their local recurrence and long-term survival. Color 3 trial is the trial that's now looking at transanal TATME, laparoscopic LAR, transanal TME, in comparison to laparoscopic LAR. Interestingly, the fallback for the procedure in this study is laparoscopy. So if you can't get it out, is transanal. So if you're in the arm where you're doing laparoscopy, and they've asked us to be part of this. We don't know if we have the funding to be part of this, but it's very exciting because we're the highest volume center in Canada, and probably the second highest volume in North America, possibly 3rd or 4th in the world. They've asked us to be part of this. It's a huge deal. But the Color 3 trial basically is saying that the one arm is going to be laparoscopic low anterior resection. Okay, the other one is laparoscopic low anterior resection transanal total mesorectal excision, and it's randomized to one patient in LAR, 2 patients in transanal. Yeah. Oncologic outcomes. So these are primarily looking at oncologic outcomes. So these were the studies in colorectal surgery that basically gave the go-ahead, yes, this is an appropriate operation to do in comparison to open. Yeah. Yes, you're looking at all those things, but the key of these was to show that they are oncologically equivalent. So that long-term survival is equivalent or better, and so basically looking at specimens, looking at all of that stuff. Yeah. So that that's basically what guides us as surgeons to do laparoscopy, and that's why we know that laparoscopy for colon and rectal cancer is appropriate. Now, this 3rd study is looking at TATME, okay, and the preliminary outcomes have shown that actually it may be even better for. We are just trying to show equivalence, but it may be even better for lower 3rd rectal cancers, okay, just because of the visualization. So what are the advantages of laparoscopy? So shorter hospital stays, improved cosmesis, less postoperative ileus because less manipulation of the bowel, faster recovery. Healthy patients with no comorbidities at Eagle Ridge are going home on an average of 3 days, so between 2 to 5 days. Faster return to normal activities, minimal pain. Again, better preservation of respiratory function and smaller scars. So 3 to 4 or 5 millimeter incisions. Yes. Yes, so I'm going to talk about that in a little bit. So, we know that laparoscopy in itself has a diminished impact on the body's physiologic response. So there's many studies that demonstrate this. And I'm sorry, because I was called in at 4 this morning for that case, I was going to put up all the studies here, but I didn't have a chance. So, but I'm sure you all have access to that and are very well aware of this. So, but again, we know, and this is why ERAS has actually, the recommendation is for smaller incisions, laparoscopy. We know that the physiologic response on the body is less. Possibly there's less, again, physiologic consequences with complications of these surgeries, such as anastomotic leaks, which can be absolutely devastating. And there hasn't been anything looking at this, and we may try to publish this because I think that that's really important to share the good and the bad in procedures that are innovative and new and being learned. And this is what happened, with laparoscopic cholecystectomy as well, right? That's how everybody found out about bile duct injuries, and because there were, we shared them and we said this is a concern and this is something that we have to look out for. So what about effects on oxygenation? So there's many studies that are looking at laparoscopic surgery in the obese patient. A lot of them again are on patients that are in gynecologic surgery, bariatric surgery as well. But bariatric surgery they're not in a significant head down position. So the studies looking at the obese patients have detected that there's significant changes in respiratory mechanics with the head down position. And despite this exacerbation of pulmonary mechanics with pneumoperitoneum, there was not a significant change in oxygenation. And this is in multiple studies. So if an obese patient, basically they say that if the obese patient can tolerate anesthesia and supine positioning, which some of our patients can't, which is necessary for both laparotomy and laparoscopy, obviously, then they're likely to tolerate the changes in position and pneumoperitoneum as well. Interestingly, again, these findings hold true in patients undergoing bariatric surgery with no differences in respiratory mechanics or arterial oxygenation during laparotomy or laparoscopy. But again, bariatrics is different. They're head up for bariatrics. So pain control. These patients don't need, as you know, they don't need regional anesthesia. Everyone is familiar with ERAS. What are the chances of these patients, of us converting in these patients? We have yet to convert to open in our 47 patients. We had a patient that we thought we may need to that last week that was had a previous low anterior resection for a rectal cancer 2 years ago, had a recurrence at his anastomosis, big recurrence, had previous radiation for prostate cancer, basically all the worst things, right? And we thought this guy's going to be a nightmare. Everything's going to be stuck down. We're not going to be able to do it laparoscopically. But we did. It took a little bit longer. It took about 4.5 hours. That operate 4.5 to 5 hours. But he got it all done laparoscopically and did very well. And that patient had something called a laparoscopic APR TATME. So you can also do an APR TATME. It's just a little bit of a different setup from the bottom end, okay? So again, what's the effects of steep Trendelenburg? Most of the literature on the influence of this and CO2 peritoneum on cardiovascular, cerebrovascular, and respiratory homeostasis is in I think I said in gynae and bariatric, but it's actually gynae and urology mostly because of the head down position. So most of the literature is in there. Again, the chances of conversion in these patients, minimal. So what's the future of this operation? So this is the COLOR 3 trial. It's this international randomized controlled trial comparing transanal and traditional laparoscopic TME for rectal cancer. It's out of Amsterdam. The fallback for this procedure is transanal, so those patients, and not opening. So those patients who are randomized to the arm where we're doing laparoscopic LAR, the fallback is transanal, and it's recognized that it's recognized in all the surgical literature that opening a patient, particularly a male obese with a narrow pelvis, does not make things easier. And George Melick actually, discussed this the other day at a dinner we were having, about the, the dread that surgeons feel the night before they're doing an LAR. Like, oh, am I going to get it out? Am I going to get into the mesorectum? And am I going to get into the nerves of the pelvis? Am I going to, this operation is meant to make that better, I think. And I think that it has changed our approach to low rectal cancer, and which is unbelievable. All surgeons, every surgeon has had that patient where they've been going laparoscopically or open from the top, and they cannot get past that tumor. And that is the horrible feeling, and it's a horrible thing for the patient, and their recurrence is almost guaranteed. And to die a pelvic death with tumor left in your pelvis or tumor recurrence in the pelvis is a horrible pelvic death is horrible. So far, what have we done at Eagle Ridge and RCH? We've done 162 patients totally, 115 TAMIS local excisions, and 48 TATMEs between the two hospitals. It's the largest series in Canada. At this point, we're the largest volume center, which is cool, and the third largest series in the world for all TAMIS. Locally, myself and Dr. Ashmala, who's Shadi Ashmala, is an oncology surgeon in Toronto at Sunnybrook. He's the second highest volume TATME surgeon in Canada. We're running this Canadian Congress in June 2nd and 3rd, and we're bringing Antonio Lacey, who's the original person who developed this procedure in Spain. We're bringing world-renowned experts from Amsterdam, from Brussels, from a couple of places in the US and from Canada in this field of transanal total mesorectal excision, and just to share their expertise and have and introduce this technique in a safe and rigorous manner to the Canadian surgical population. So we've got general surgeons, colorectal surgeons, surgical oncologists coming from all over the country. So that's very exciting. What do I want to leave you with? The majority of the cases we do are just the TAMIS cases, the run-of-the-mill daycare procedures. We've done, like I said, 115. They go home post-op day 1 generally, unless there's any other reason, but it's like a hernia, and less pain, minimal complications, rare entry into the abdomen. We've had 3 patients that we've entered into their abdomen, and that's unanticipated based on height of the tumor. All it depends on is how low the patient's peritoneal reflections are intra-abdominally. So skinny women is generally, but we've entered in on a male too. Some of them have had to have a repair from the laparoscopically, and they're all aware of this, that this may happen. And some of them have had to have an LAR, so an actual, resection of that area and a reanastomosis. But again, the important thing to understand is that their alternative would have been a segmental resection. Okay, so all of these patients prior to TEM or TAMIS would have had segmental resection. So it's a huge impact. RCH versus Eagle Ridge, again, more comorbidities at RCH. Occasionally, we get these reoperative nightmares, and this is just the type of referral that George and I get because we're the only 2 colorectal surgeons for, like, I don't even know what Fraser Health is now, 1.2 million, 1.5 million or something. It's, we're getting there, and, there's certainly a learning curve with this. We're at 47 cases, and I, never thought we would approach what the experts talk about in Spain, getting down to doing this in, they say, oh, we do this in 3 hours. Well, we did, we've done a couple now in 2.5 hours, and so, that learning curve exists, and it's when you're learning a new operation, that's definitely, the thing, and I'm sure, like, you feel similarly to my daughter, this focus on TATME and TAMIS is just annoying, and it's like, just get it done already. But be patient with us, and we'll get there. So, thanks everybody. Any questions? Richard, you can't keep quiet. Come on. Yeah. Yes. Yeah. Yeah. So, I always tell patients we can do any operation is the right thing to do. So we can do an anastomosis. Like, we have a 70-year-old patient who comes in and has a big rectal tumor that's either invading the sphincter muscle. So if it's invading the sphincter muscle, that's an absolute indication for an APR. If it's low rectum or even mid rectum, and I'm going to leave the patient that much rectum, they have that much. The rectum is what holds onto the stool and causes their, like, helps with their continence, right? So basically, I'm going to be giving that person who's had, like, let's say a kid and has stretched out their sphincter muscle and their pelvic, nerves and their sacral nerves, and, they have a bit of incontinence already. Connecting them, despite the fact that that might be oncologically okay, is functionally not a good idea. So those are the patients I tell them, an APR is a good idea for you, and a permanent colostomy. Now, what we do is we don't use this port. It's a similar port. It's the SILS port, and it's called the single incision laparoscopic port. Basically, it's the same path, but a different like that goes in. And what we do is we start the APR open, like we would normally start an APR. We get into that same space that we would get into with the PATME, so which is the mesorectal plane. As soon as we see the mesorectal plane, we insert the port, and we purse string it so it's like held in basically by the perineum, by the skin of the perineum. So it's the same operation. I'm just using a bit of a different port because of the technical issues. And Dr. Melick has brought in, he does what's called we used to do conical APRs where we go in like this, and we would sort of do what is that called? Like a little, like, wedge? Hourglass, yeah. And basically we know that's oncologically also not good. Okay, so when George came, he's been doing this in the U.S. for a couple of years, and he does very nice straight anastomosis cutting through the levator muscles. You don't need your levator muscles if your anus is gone, and we know that the oncologic outcomes are better for that. So he starts it like that, then inserts the port and starts the dissection. And we do that for like we do TATME APRs for patients who have residual rectal stumps and don't need their anuses. So we cut out the anus, then we insert the port and start. Any other questions? Yeah. Yeah, so it's interesting. So this procedure was actually brought up for that obese male with a narrow pelvis. So when we first started doing it, it was like a save. Do you know what I mean? It was like we would start laparoscopically and realize, holy crap, like there's just this big fatty rectum stuck in this pelvis. I can't get any instruments, let alone my hand, around it. So it was actually brought in for those patients to do the dissection from bottom up. Now, the head down positioning is for the LAR. The head down positioning is not for the TATME. So TATME, you could have a patient head up, it wouldn't matter. You're not doing any kind of retraction. It doesn't matter if the small bowel is sitting in there until you've entered into the abdomen, right? So those obese people, if they are candidates with their comorbidities and their obesity for a regular operation, then they should absolutely be a candidate for this. And this is, it's actually, I don't want to say it, but it's actually easier than, I wouldn't say easy, but it's easier to do that in that patient transanally than it would be through the abdomen. Yeah. Yeah, you know what? It's absolutely a concern. And actually, where I trained, we used a bean bag for all those patients, and we would tape them across the chest. And I know George does that oftentimes, so he will tape them across the chest so that they don't slide. And and the bean bag is good because you can bulk it up here so that when you put the patient in severe head down, they don't slide. Unfortunately, the equipment we have is not good. The great thing about this is that the foundation here at RTH, they know all about this procedure, and they are excited about it. And they have actually they actually sent me an email last week and said, "Oh, we'd like to meet with you so you can tell us what equipment you need." And I was thinking, we don't really need any equipment. I was like, we kind of have everything. We got our new tower. We got but I'm like, they're trying to give me money. So I'm like, okay. So that's actually, and I actually haven't thought about that for a while. So I'm glad you brought that up because I'm going to ask for that. So that's a great question because I've had quite a few meetings with, oh my gosh, who's the head of the internal medicine there? Oh, yes. Oh my God, I'm blanking. Julia Morley. Julia Morley. So we've had a lot of, so with Patty Johnson and Julia Morley, Dave Conkin, myself, and administration there as well to discuss like what, where are we going with this? How can we, right now right now we're doing, the obese patients are being done here. It is a bit more of a challenge here. This is it's a high volume hospital. It's a trauma hospital. It's, we've done more of these at Eagle Ridge. They know the setup. They've watched the videos. They're like totally engaged. 3 of our nurses are coming to our Congress in Toronto. Like it's a setup, but I think we can translate that from Eagle Ridge and make this a great center too. In terms of doing obese patients over there, I think Julia's long-term sort of view is that we make it a bit more of an acute hospital, and she is on board with these cases, and so are like all the other internal medicine doctors, the hospitalists. It's actually pretty wonderful. Yeah. Yes. No, not in the TATME literature. And actually, even looking at the gynecologic literature and the urologic literature for these cases, those are oftentimes prolonged, like hysterectomies, 4-hour hysterectomies in speech and Ellenberg. I actually couldn't find anything, and I was looking for it, and I'm sure there is. But certainly, again, if there's concerns, like oftentimes you'll see we'll be done the abdominal portion, you can actually put that patient head up. And a lot of the time we forget, we're so kind of immersed in what we're doing, but the TATME portion does not actually need you to be head down. So that's sort of like, and we forget, like we're sort of doing our thing. I want to look from this side, but we don't need to, if the patient is compromised at all, we're happy and we actually should be putting them up at that point, once we've done the abdominal portion, because there is no need to keep doing that. Yeah. I mean, I think, as the procedures get longer and they're more complicated, and I can tell you, like, John, the longest one we had, it was like 4.5 hours, and it was quite a complicated case. Like I said, the pelvic radiation, the previous anastomosis, so he'd had a previous TME, a previous total mesorectal excision already, and then we're doing it again, getting back into that space. I mean, that's like the worst consequences, right? So, and again, I did not believe the surgeon in Spain who said, "Oh, we do these in 3 hours." I was like, "There's no way." And now we're doing it 2.5 hours at Eagle Ridge with these, healthy patients, and so it's exciting. It's an exciting time, and thank you for being part of it. Can I just unplug it? Yeah? Or do I have to? Yeah, okay. Oh, there we go. I was trying to do that. Thank you. You know what? That Congress that I told you about. So we are trying. What we want to do is, so